So case today is basically, we're going to discuss the emerging role of CCTAs. Patient was 67-year-old male, history of 2 syncopal episode, and worsening dyspnea on exertion. HPI patient basically came to the ED with 2 episodes of syncope. First one, he said while he was in the shower, he been lightheaded, sit down but passed out, hit his head on the floor, got back up, went to the bed and passed out again. In addition to syncope, he reported shortness of breath on exertion, which was mild and progressively getting worse over the past several months. Denies any chest pain before or after the syncope, no history of palpitation, dizziness, or nausea. He denies any infectious symptoms.
If you want to. I'm not sure. Hope not.
That should be a cath. That should be
Oh, yeah.
So past medical history-wise, hypertension, hypothyroidism, GERD, and BPH. Social history is a former smoker, quit 3 years ago, roughly 30-pack-year history. Family history, negative for coronary artery disease. It's never had cardiac workup done. Medication-wise, on some blood pressure medication and levothyroxine for the hypothyroidism. Physical exam was benign, just a little orthostatic on presentation, which improved on fluid administration, but otherwise physical exam was also benign. This was the EKG on presentation. So normal sinus, regular rate of rhythm, so left anterior hemiblock, but otherwise no ischemic changes, no T wave, vested depression, anything like that. Labs wise, just a little hypokalemia, but nothing crazy in the CMP. Probes were negative and flat. Pro-BNP was less than 36 and A1C of 7. So in the ED initially, he got a chest X-ray, which was negative. He got a CT head because of the fall, which was also negative. The CTA of the chest was negative for pulmonary embolism and showed some mild inflammatory versus infectious changes. Patient was admitted to the observation unit and cardiology was consulted for syncope. No arrhythmias were noted on the tele and cardiology recommended outpatient follow-up for ischemic workup. His blood pressure medication was held due to the possible orthostasis. Patient presented the outpatient cardiology and was recommended a CCTA. So we just went over this. So this would be our LAD and D1 heavily calcified. The left circumflex is just taking off here, also very heavily calcified. The RCA going all the way back to your descending, heavily calcified vessel. So this was the other view that we were talking about. So this is showing us the coronal view of the vessel. This is the RCA. As you can see, significant lesions at the proximal and mid RCA all the way down. Oh. And this would be the LAD. So LAD is relatively okay. No significant lesion. Left main looks okay. And a little lesion in the D1 section over here where the diag is taking off, proximal D1. But otherwise, the LAD looks okay. And this would be the circ, significant lesions. This here looks like 99%, but significant lesion in the mid circumflex as well. This is again the RCA, LAD.
Great pictures.
Yeah. So how they do this scan?
You're not surprised. You're not surprised.
Yeah. No, that's what I was going to tell you. We moved a long way.
Oh, okay.
So just to go over again.
It's like they put these in a textbook.
Yeah. So this is the LAD, slight D1 lesion, circumflex throughout, especially mid circumflex, the OM. It's the RCA again. LAD. It's a small LAD. It's not a huge LAD. The circumflex is the dominant vessel. So this is the extra information that we get nowadays with the CCTAs. It's called an FFR. So basically the concept behind the FFR is that when we do invasive catheterization, we have the ability to measure difference in pressure proximal and distal to the lesion. That gives us a somewhat functional idea of how severe that lesion is. So now with sophisticated algorithms, we can predict that FFR using CAT scan as well. So anything below a 0.8 is an intermediate to severe lesion, which correlates with positive reproducible ischemia. So over here, we have the RCA, which looks for the most part, okay, greater than 0.8. But if you look at the left side, again, a small LAD, but and the circ has some significant lesions which are less than 0.8. Here are the vessels separated. So LAD looks okay, but the circumflex has significant lesion like mid and distal circumflex. And then the RCA has some lesions distally. So this CCTA was read as calcium score of 2028, which is very, very high. LAD had moderate stenosis proximally and moderate to severe stenosis distally, and severe stenosis in the diagonal D1 branch. Circumflex had moderate stenosis proximally and moderate to severe stenosis distally, and RCA had severe stenosis proximally, and left main was normal. Patient was scheduled for an elective cardiac catheterization. So this here is an RAO caudal view with the circumflex coming down and the LAD on top. So left main looks okay, it's a small left main. If you look at the circumflex, there are several lesions in the mid circumflex region. Right here, right here. And if you look at the OM, just off like the proximal OM, there's significant lesions here as well. LAD is not well visualized on this view. This is again the same view. This is a LAO crani. So on this view, the LAD is on the left side coming down. The D1 is a major branch from on this patient's heart. LAD is a small vessel for some reason. The severe stenosis that we saw in the CCTA is not seen on the coronary angio that we had here. The circumflex goes on the top. It's like the OM branch. LAD looks okay. This is the same LAO crani. So this is the RAO crani. Over here, we have the LAD coming down with the D1 over here, and the circumflex goes back. I think this is probably the OM that's we're seeing from the other side. Correct me if I'm it's like the OM.
I think that's the circ actually.
That's the circ.
That's the circ and the OM is going up.
Going up. Oh,
That's the one.
That's the one.
That's
Okay.
the
But this is the LAD and this
That's the LAD.
this was the D1.
Branches, yeah.
This is a similar.
So in the area of cranial, the LAD would be on top, going around the heart. But like you said, it's a small LAD, barely reaches the apex of the heart.
Yeah.
But the D1 is pretty big. That's all.
So this is interesting because our CCTA showed severe stenosis of the D1, but over here clearly that's not the case.
Yeah.
So same view. So this is your RCA with the posterior descending RPL branch. The RCA is some mild stenosis with RCA, nothing crazy right here. This is also your RCA, same. This is another view of the RCA. It's a lot of foreshortening here. Same mid RCA lesion. So this is the chart. This is basically they engaged the left circumflex and now they're placing a balloon to form proba at this peak. So they put a balloon in, they inflate the balloon to make room in the lesion to then put a stent in. So these two markers show the extent of the balloon. And this is a very fast clip. If I play it, it's gonna disappear. So. Same case. So this is a balloon which is a little proximal to the prior balloon. So they provided twice the vessel. So now they're providing the OM1. So this was the circumflex, this is the OM, and now they're ballooning the OM right here. Similar with deploying the stent. And this is after the stents have been placed. So you can see there's more flow in the OM and mid circumflex. This is the ariocranie again. This is post-stenting. You can see there's a stent here and a stent here. Possibly distal stent. Do you think that's a stent?
Yeah.
This will be a stent here, or?
Yeah,
that's a stent. Yeah. So the two stents, 1 and 2, and then the OM has a stent.
Yeah. Yeah, you can see now that the blockage is gone. Yeah. So very good correlation with the CT, actually, if you remember the CT looked great. And like you said, the technology has improved significantly nowadays. And now that we can do the FFR, I'm sure you're going to talk about that. I might need to go and do this test.
So this is an LV gram. Basically, they shoot a dye in the LV and see the function of the left ventricle. That's how you get the EF from a cath. Typically, they use a pigtail catheter, but in this case, they use a regular catheter for angio. Looks like a good squeeze. No MR spotted on this. So the cath report was severe 3-vessel disease, circ long mid distal 95%, OM with 90%, and RCA mid with 90%. Preserved EF 60% of LV, DPO 14, 2 stents to the mid circumflex, and 1 stent to the OM1. No complications. Patient was discharged home on aspirin Plavix with plans for stage PCI to mid RCA in 4 weeks. So now we're going to talk about the role of CCTAs in non-invasive evaluation of ischemic heart disease. So first off, what's the purpose of non-invasive ischemic evaluation, right? So our goal is to figure out whether patient number 1 has, in fact, coronary disease. Or if patient has coronary disease, what's the extent of that disease? Is that something that needs to be intervened on, something that we can manage medically? The whole goal being to prevent or avoid as many invasive procedures as possible. So that's the whole goal behind non-invasive ischemic evaluation. So what's the hallmark of a good non-invasive test? The test should have high diagnostic accuracy. It should have some prognostic values. It should be safe, cost-effective, consistent, and should be done in a timely manner. So these are the current non-invasive tests that we have today. It's exercise stress test, nuclear stress echo, cardiac MRI, CCTA with FFR, and PET scans. We're going to talk about the CCTAs today. Basically, after the introduction of 64 slice CTs, that's when the CCTAs came to the forefront. Main key clinical applications were stable chest pain with intermediate risk and acute chest pain to rule out MIs. And they've been proven to have great prognostic value when compared to other modalities. As far as the numbers are concerned, we have a 91% sensitivity and 92% specificity with a diagnostic accuracy of 91%. And this is all compared to the gold standard, which is your invasive coronary angiography. So what are the key trials supporting the CCTAs? The first one we're going to look at is the PROMISE trial, which was conducted in 2015, published in New England Journal. So it was a huge trial of 10,000 patients with stable chest pain, and they were randomized to either CCTAs or functional testing like stress test. And the results showed that was CCTAs and functional testing and no difference in discriminating between cardiac ischemic disease and non-cardiac disease. And it significantly reduced unnecessary invasive coronary angiography, and we'll go into more detail what that entails. and had significantly low complication rate. So it was a safe test which performed on par with functional tests that existed at that time, and it reduced the burden or reduced the chances of patients getting invasive testing. After that, this was the Scott Hart trial, which was conducted in Scotland, a multi-center study, 4,000 patients, which compared CCTA to standard of care, and they found that CCTAs added to standard of care improved the diagnosis of angina and better treatment for patients. And it led to majority of the patient being reclassified as far as their risk stratification was concerned, which was a huge step. And this was also one of the first studies to look at long-term outcomes. And at 5 years, it showed a significant reduction in fatal and non-fatal MIs in the CCTA group, which was a huge thing in cardiac imaging. The other trial that we're going to look at is the ROMICAT-2 trial, which was published in 2012 in the New England Journal. It looked at the role of CCTAs in the emergency department. So the biggest advantage of CCTAs over conventional non-invasive testing is the turnover time. So you can basically get a CAT scan done and read around the same time you can get a CTPA read. So that's the biggest advantage over like a stress test, which requires text, which requires specialized reading, takes a lot of time. So they did the study in the EP. They looked at 1,000 patients who were randomized to either CCTA or standard of care, being functional testing. And they found that CCTA significantly reduced length of hospital stay, time to diagnosis, and total ED costs. So if your patient is getting discharged sooner, you're freeing up a bed sooner, right? And that's going to save you money. And increase the rate of direct discharge from the ED without compromising safety, which is a huge thing when we look at, lawsuits and all the legal aspect. So it proves that CCTAs can efficiently rule out ACS and reduce unnecessary hospitalizations. This was another multi-center study, the Crescent-2 trial, which was published in JACC Imaging in 2018, it's more recent. And it compared the effectiveness of CCTAs against functional testing for diagnosing coronary artery disease in patients with stable chest pain or stable angina. And CCTAs were superior to regular functional testing comparing when it comes to identifying obstructive coronary artery disease. It also reduced additional testing, invasive procedures, and overall costs. So far what we've discussed is all CCTAs when it comes to anatomic testing, right? So, but there comes a point where we need functional data. So nowadays we have these modalities where we can use CCTAs to assess the patient's functional status in terms of coronary artery disease. So the two methods that we have is stress myocardial CT perfusion and the fractional flow reserve CT, which we used in our patient as well. So this is an easier way to get it. It relies on a lot of sophisticated algorithms which calculate the FFR for you. And it's been validated by multiple trials that we're going to go through and show that it's just as good as invasive FFRs. So this was the next trial. This was a multinational study conducted in 2014, published in JACC. Basically looked at FFR CT versus invasive FFR for assessing coronary artery disease. And compared to invasive FFR, it showed 86% sensitivity and 79% specificity, which is a huge thing, and improved diagnostic accuracy over CCTAs alone. It also reduced false positive and unnecessary invasive coronary angiogram, which is our main goal, basically. The patients who don't need an angio should not get an invasive angio. The other study was database-based studies based on the advanced registry published in JACC Imaging again, 2020. So they basically looked at long-term outcomes of patients who underwent FFR CT-based decisions. So 66% of the treatment plans were changed based on FFR CT, which is huge. These were 66% of the patients who either would have gotten cath or would have gotten discharged and labeled non-coronary artery disease. And 61% reduction unnecessary invasive coronary angiography, which is a huge thing. FFR CT guided care led to better clinical outcome, the more selective revascularization, and it was obviously cost effective as well. Because these patients are getting discharged from the ED, these patients are not coming for invasive cath, they're especially not staying in the hospital. The platform study was a 1-year study, which assessed the FFR CT outcomes, published also in JACC in 2016. And it showed that CCTA reduced the need for invasive coronary angiography by 61% as well. So this has been validated across multiple studies. It's not just one study that showed benefit. Multiple studies have showed that CCTA's FFR reduce patients' chances of getting invasive coronary angiography. So what's the prognostic power of CCTAs? So there are two kind of things that we can use to prognosticate patients. There's number one, the patients without coronary plaques. So if your CCTA shows that you don't have any plaques, you have excellent prognosis. If it shows non-obstructive lesions, then we can be more aggressive about it. These are typically the patients who would go unnoticed, right? These are the patients without chest pain who would otherwise not get a cath. So now we have more information on these patients. And even though they're not having chest pain, they have significant coronary artery disease, and we can better treat that now. There are other sophisticated scores that are used to classify plaques, and based on these scores, you can basically prognosticate or risk stratify these patients. So what do the guidelines say? So these are the latest guidelines by the ACC and AHA published in 2021. So they give CCTAs a class 1 recommendation for stable chest pain in patients with intermediate pretest probability. Because this also gives us the ability to anatomically assess the patient, which is something that we don't get with traditional functional testing. In acute chest pain, the guidelines give it a 2A recommendation for CCTAs. And as far as risk stratification and prognosis is concerned, CCTAs also get a 2A recommendation. And as far as FFRCT is concerned, ACC and AHA maintain that it should be used on a case-to-case basis to augment your CCTA. In my personal opinion, this is very conservative. I think we have moved to a point or to a technology where we can get a lot better results than those studies showed back 10 years ago or 12 years ago. And I feel like these guidelines need a revision, and CCTAs should really be signed. Common indications for CCTA in current guidance: stable angina or chest pain, acute chest pain with low to intermediate risk, coronary anomalies to better understand the anatomy, non-invasive risk stratification, this is done in the outpatient setting, and pre-procedural planning for possible high-risk cases, TAVR, structural cases, all that stuff. So when do you choose a CCTA over a stress test? So whenever you need anatomical evaluation, CCTA is your go-to, because your stress test will tell you about functional status, but they won't tell you about the anatomy of the patient. Whenever a functional test is uncertain, most of the time, as you guys probably know, you get a stress test and it says intermediate for coronary. What is that? You don't know. So that's when you do a CCTA. The ED, when you're suspecting like low to intermediate risk CAD, but you want to discharge the patient, you want to keep the patient, you can do a CCTA and then ED and then discharge the patient. And obviously, negative stress test with persistent symptoms. When do you choose a stress test over CCTA? So one of the limitations of a CCTA is when you have heavily calcified vessels, you cannot get a good idea of the severity of the lesions. So in this case, functional testing is somewhat better. Known severe coronary artery disease, when you know someone has severe disease, you don't need to give them contrast and put them through radiation. You can just get a stress test to kind of assess whether their lesions are causing them symptoms or not. And post-revascularization. So when you have cabbage is done, PCI is done, your anatomy's been changed, it's very hard to interpret CCTAs in this case. So what's the future direction? So now we've got new modalities coming in, dual energy CTs, which can actually classify plaques and tell you what's the high-risk plaque and what's a non-high-risk plaque. There are several trials going on which are comparing CT perfusion to FFR CTs, which will be very interesting to see because they're both giving you functional data. They're also, this is not the future, we're living in this future. We're already using CCTAs for complex interventions, through vessel disease, and biomarker integration where we can get better plaque burden analysis based on cardiac biomarkers. So this is basically a summary of all the non-invasive ischemic evaluation tests that we have available today. And as you can see, the CCTAs and CCTAs with FFRCT have by far the highest sensitivities, highest prognostic value. They're relatively safe. They're reproducible, as we've seen with multiple trials showing consistent results. They have high diagnostic utility, they're cost effective, and the biggest thing is turnaround time. you can get a CCTA read in a couple of hours, whereas a stress test, logistically speaking, takes a longer time. Questions?
So the FFR, talking a little bit, so the CTCA or CCTA gives you an anatomical image of the coronaries, right? Which is very good for risk stratification. If we have patients that we don't know if we should start statins or not, we can use this to assess if there's a high calcium scoring, there is some plaque buildup, and we can decide if a patient needs or doesn't need statin therapy. Patient needs further evaluation, go for an invasive procedure. The FFR, what it has done, it gives us the physiological significance of a stenosis, which is very important. You may have plaque buildup, but maybe it is not physiologically important. It's not reaching a 70% stenosis, which above which you will get symptoms. So it is very important. This test is not done everywhere, right? It is done under some patent in Los Angeles, right?
Yeah.
I don't know if you know about that. It's a company, some physicians created these companies. And so all the tests are being sent to Los Angeles, and that's where the FFR is being done. So you send it, and they send it back with the numbers. All right. So what it tells you is this stenosis significant or it's not, based on fractional flow reserve, what it's called. Yeah. Non-invasive fractional flow reserve, and a value that is below 0.8, then it is significant. So I think it is changing the way we manage patients to death. But you have to remember, in patients that have severe calcifications, CT is not ideal. Yeah. So in the elderly population, it's not the best test because they will have calcifications. And when you have calcium in the CT, that's that blooming artifact. So you have you cannot see very well the lumen. And in patients that already had stents, yeah, it's not very good, right? Because if you have metal inside the artery, you don't know how stenotic that could be or it's not, right? Unless the stents are very big. In that case, yes, it is. But if you have anybody that already had intervention, this is not the test to have. So very good for younger patients, very good for, chest pains, patients that are not acute coronary syndrome. So those are the things to remember.
I think as with all tests, you got to pick your population, right? Yeah. So this is what that Dr. Cooper is saying.
Would you recommend this test for a patient who recently get diagnosed with diabetes and we were thinking about whether to do statin or not? They go to the test and see.
Yeah, so that's a good question, right? So before CCTA, what happened to these patients, right? You either offer them statin, they refuse it, that's it. These are the patients, they don't have any symptoms, they don't get their non-invasive test, like stress test is going to be negative. And you're definitely not going to catch these patients. So how do you know they have coronary artery disease? So this is where this comes in. So these are the patients who are not getting CATs, their functional tests are going to be negative. But when you do a CCTA, you're going to see either high calcium deposits or you're going to see lesions that are not functionally significant or physiologically significant. So this helps us guide treatment for those patients who are diabetics, no chest symptoms, but you don't know if they have coronary artery disease or not.
Diabetic probably will have to be on a statin, right? If you have a patient that has high LDL and is diabetic, probably that patient, if you do the risk calculation, will need statins, at least moderate dose of statins. But you have other patients that, you are on the fence, right? They have a typical chest pain or, you don't know what it is, or they have a high cholesterol, but they don't have any other risk factors. So you want to make a decision, should I give this patient statin or not? And this kind of helps you cut down. So definitely we're using it a lot. I mean, it's much easier and better than a, stress test.
My question with this is, in an outpatient setting, can we rely on a stress test to monitor progression of, let's say we do a stress test, put someone on statin, do we repeat a stress test?
So you start with the CT, and the CT tells you, okay, the patient has a 50% mid-LAD lesion.
Yeah.
So you put him on statins, and you pray for the best, and there's going to be lack of progression of the disease, or there's going to be regression of plaque, which is rare. And after a couple of years, actually, I just saw a patient, young guy, and he had a cath 8 years ago, 6 years ago. He had a cath 6 years ago, mid-LAD, We did an invasive cath. We did an FFR which was negative. And now what do I do with this patient, right? We know he has plaque. It's 6 years later. He's asymptomatic. Should I do a stress test? Should I send him for a CT? Do nothing. If he's asymptomatic, do nothing. He's feeling good. I'm not going to make him feel better. But he has a very, very strong family history.
Does he want to know?
Huh?
Does he want to know?
He does. His sister just suddenly. So this is a true story from half an hour ago. His sister, she was 70 years old. He's 63. And he rides bicycle like crazy. He does this extreme biking, all the way to Montauk and back in half an hour, whatever. Anyway, very, very fit. His sister, 70 years old, went to the bathroom during a dinner and never came back. She collapsed in the bathroom, died. So he's freaking out, and he has this very, very strong history of ischemic heart disease. So he says, I want to do something. And he had this medial AD 50% 6 years ago. So I sent him for this CTCA with FFR. It's going to tell me, is there plaque, no plaque? And the FFR is going to tell me, is this something that needs to be fixed or be followed up? But we have more options, and the guidelines getting more complex every day. Definitely something to think of.
Definitely the future.
It's not the future. It's right here.
It's right here.
Right here. Yeah, we're doing it. And then South Shore Hospital, they do it really good. We have a good cardiologist, Dr. Yang. He's very good at this, and he's on top of it. So I like to send my cases to him, and I know that I'm going to get a good, reliable response.
Any other questions?
So if you were to use, like in a case of stable income, you're talking about 50% blockers that you find, so now you could risk stratify a little bit more and say, I want to put them on the statin, 80 milligrams to our statin now. When would I want to reassess with what I want to?
That's a good question. We don't know. If the patient is completely asymptomatic, the guidelines say you shouldn't need to reassess. Because we know, unfortunately, as much as it hurts me to say, doing invasive angiography, balloon stents, they do not change the outcomes. It doesn't change mortality. All that it changes symptoms, right? So it's very good for symptom control. And even that is, with the ischemia trial, courage trial, all those trials, that's also being questioned nowadays. You have a patient, you put him on a atorvastatin, patient is asymptomatic, leave him alone. Yeah, we don't do testing. If the patient is diabetic, you can probably do some testing because you can say, he has diabetic neuropathy, probably he's not going to feel pain. You can do some proactive, every 2 years do a stress test to make sure that there's no silent ischemia going on here. And we have a study coming. We're still good for that one. All right. Thanks, everybody. Very good.
Thanks.
Like pictures. Oh, so those got to be sent to California.
Yeah, so
What do they charge?
probably a lot.
Probably
So
a lot.
not doesn't
So
automatically.
they actually would send a disc or whatever it is, they have to send a disc.
So not doesn't automatically do it. You have to request it. For Stony Brook, they send all of theirs.
They do. I mean, I would think if you're gonna do that test, you want that extra information for the flow reserve or whatever is spent.
No, I guess if it's negative, you don't need a full.
Well, yeah, that's true. If something-
Save money there.
Yeah. Yeah, the other thing was that for patients with asthma, COPD, you probably can't do this test because you got to get rid of blockers to slow it down.
They beat them in radiology, and I kind of beat with them, and it's all algorithms. They don't do anything manually. Computer reads it. They just select a vessel and the computer reads it.
Radiologist, just get a machine that AI do and you know.
So a cardiologist needs a radiologist co-signer, but a radiologist doesn't need a cardiologist co-signer. There are residents sitting there reading.
Too many from our hospital.
I know it well,
Very rarely see.
but outpatient is well. Dr. Matilsky and
Even on OBS, every once in a while, we'll see somebody on OBS get a test. It's rare.
it's very just not well adopted.
Yeah, right.
Questions? Yeah.
In situation, I mean, what I've been looking to a lot recently and reading about more is that this stable CAT tends to be medical management versus PCI has no mortality benefit, right? So in a case where using this for analyze some of the stable CAD, why would I look for PCI in different situations? They're equivalent outcomes.
So that's a good question. And